well. She is 38 weeks pregnant and in labor. And right now, before we go on to external and internal fetal monitoring, we are going to auscultate for the fetal heart sound. Before auscultating, you want to make sure that you know what position that the fetus is in, because this will determine where the baby's back is, which is the best place that you would like to auscultate for the fetal heart sound. Now, for some examples would be if the baby was in a breech position, the back would be more up here. So you would want to auscultate above the umbilicus. Whereas in a cephalic position, then you want to auscultate below the umbilicus. Another way to assess the fetal well-being is by using an external fetal heart rate monitor. By doing this, you'll use two different kinds of transducers. One is the topo transducer, which will monitor the mother's uterine contractions during labor, and the second is the ultrasound transducer, which will monitor the fetal heart rate. You will always have one ultrasound transducer per fetus. So if the mom is having twins, you will use two ultrasound transducers. Now, when placing the transducers on, you want to make sure that there is gel on the bottoms of both. That way it'll help with the conduction. And then you would place them on the mother's abdomen and then make sure that it is secure with the fetal strip. That way it'll keep the transducers in place. External fetal heart rate monitoring is used in pregnancies that are of high risk, and also in pregnancies that have labor induced by Pitocin, or even in cases where there are non-reassuring fetal heart rates. Now, some of the disadvantages of using the external fetal heart rate monitor is that the mom will have limited physical mobility, but that also comes to be a good thing for the external fetal heart rate monitor is that because it is on the outside of the mom, it is less invasive towards the fetus and the mother, and it is also poses less of a risk of infection. Another method that you may see and observe in the OB clinical setting is the use of an internal fetal heart rate monitor. This is a very invasive procedure, but it is very accurate in telling whether the fetal heart rate is reassuring or non-reassuring. So since it is invasive procedure, then only physicians or midwives or specially trained RNs are allowed to do this procedure. What they will do is they will take a spiral electrode and they will insert it through the vagina and attach it to the fetal scalp. And then they will attach and secure the cord or the spiral electrode wire to the mom's leg. And to measure the uterine contractions, they will use a IUPC, which is an intrauterine pressure catheter. This will assess the mother's contractions for their frequency, the duration, and their intensity. But in order for the internal fetal heart rate monitor to be used, the mom's membranes must be ruptured and their cervix must be dilated to 2 to 3 centimeters. And this procedure is usually only reserved for the high-risk pregnancies.
When you're monitoring the fetal heart rate pattern, you want to determine the baseline. The baseline is the average fetal heart rate within a 10-minute period. Ideally, you want the baseline to be between 110 and 160 beats per minute. Abnormal variations include bradycardia, which is a fetal heart rate of less than 110 beats per minute, or bradycardia, which is above 160 beats per minute. These can be indicative of many different complications and require further evaluation. When you're determining the baseline, one of the things that you want to remember is that it excludes accelerations and decelerations, which are changes in the fetal heart rate pattern, which we'll get into later. Another thing that you'll see is variability, which are fluctuations in the fetal heart rate pattern. One of the first kinds of variability is absent variability, where you have zero change. There's zero change in the fetal heart rate, and it requires immediate evaluation. With minimal variability, you have a change of 2 to 5 beats per minute, and this can be caused from certain medications, or it can be indicating that the baby is sleeping. It requires further monitoring. A reassuring sign is moderate variability, which is a change of 6 to 25 beats per minute, and it indicates fetal well-being. A non-reassuring kind of variability is marked variability, where you have a change in over 25 beats per minute, and it can be a less common sign of hypoxia. Accelerations are an increase of the fetal heart rate by at least 15 beats per minute over the baseline for at least 15 to 30 seconds. When you're looking at a strip, one thing to keep in mind is that each box going across is 10 seconds, so that's how you know the length of the acceleration. Accelerations are a good sign when they're accompanied by fetal movement. The accelerations are going to be limited if the fetus is asleep, and when contractions are present, it's noted as a response thought to be compensation for decreased blood flow to the fetus, and accelerations can occur before, during, and after a contraction. Decelerations are any decrease in the fetal heart rate below the baseline. They're classified by their onset of early, variable, and late. With early decelerations, the onset of the decel begins near the onset of the contraction. So you have the decel starting at about the same time that the contraction is starting. The lowest part of the decel should be at the same time as the peak of the contraction, and the fetal heart rate returns to the baseline by the end of the contraction. They're benign and usually well tolerated by the fetus. These are reassuring if accompanied with a normal fetal heart rate baseline and normal variability. Variable decels are where you have variable onset, frequency, duration, and intensity, with a decrease by 15 beats per minute for at least 15 seconds, with a return to the baseline within 2 minutes. They can be unrelated to the presence of contractions, and it's thought to be a result of umbilical cord compression, where the degree of compression can change the severity of the decel. If they become more severe and longer lasting, it's a sign of nuchal cord, where the cord is wrapped around the fetus's neck. Some things that you're going to want to do is reposition the client, administer O2, and stop oxytocin if it's being administered. And again, with this, it can occur with a contraction or without. Late decels is where you have a late onset, and it begins around the peak of the contraction. So where you have the contraction peaking, you have the decel starting. The decel doesn't end until the contraction ends, and it can indicate uteroplacental insufficiency, where there's a decline in placental function. The decreased blood flow from the uterus to the placenta leads to fetal hypoxia and the late decels. It requires prompt attention because the longer that they last, the more serious they become. You're going to want to notify the primary care provider, discontinue oxytocin if it's being infused, change the mother to a side-lying position, administer O2, and prep for a vaginal or cesarean birth. And that concludes the fundamentals of fetal heart rate monitoring.